everyone, welcome. My name is Ellen Hostetler, and I'm the Chief Science Officer for the John Ritter Foundation for Aortic Health. We're so glad to have you join us today. The John Ritter Foundation is dedicated to preventing death and disability caused by aortic dissection, as well as raising awareness of thoracic aortic aneurysm and dissection. Please check out our website to learn more. We have a ton of great resources, information on getting involved in the community, participating in research, as well as our peer support program, the Aorta Advocates, which helps you navigate resources and empowers you to advocate for you and your family's aortic health. So today, I'm excited to share that we have a panel of really great experts to address some of the myths and misconceptions around thoracic aortic aneurysm and dissection. This is a complex disorder, and it can be really tricky to navigate, especially if you're reading things online and you're talking to other people in the community, what are facts, what are fiction, and a lot of times what are areas where there's a lot of nuance, or maybe we don't have great data to be able to provide a firm answer one way or the other, and more research needs to be done. So today our experts will be addressing all of these and helping us navigate some of these tricky waters. And this is true whether you are at risk for these conditions because you have a genetic aortic disease, whether you are living with an aneurysm or dissection, or you lost a family member to this condition, or you're a caregiver. You all are part of our community, and we're glad to have you here. So first, a short disclaimer, though. This webinar is intended for educational and informational purposes only and does not constitute medical advice, diagnosis, or treatment. Please always seek the advice of your physician or another qualified medical professional if you have questions about your aortic disease or your loved one's aortic disease. And if you have concerns or need assistance finding an aortic center or an expert in this condition, you can always reach out to the John Ritter Foundation, and we'll do our best to provide some resources to help you find one and navigate your journey. So with that, I'll go ahead and introduce our speakers. We have a lot of content today, and I want to get to as many myths as possible, or as many facts also as possible. So a brief introduction here, but you can read more about them in the description to this video. So Alana Cecchi is a board-certified genetic counselor who specializes in aortic and vascular disease at UTHealth in Houston, Texas. She also conducts clinical research as part of the John Ritter Research Program. Many of you may know her from there if you've participated. And she sees patients for genetic counseling and risk assessment with the Multidisciplinary Aortic and Vascular Disease Clinic at UT Physicians in Houston. Dr. David Liang is a cardiologist at Hoag Hospital in Newport Beach, California. He leads the clinic for Marfan syndrome and related conditions in the Elaine and Robert Matranga Aortic Center. Dr. Liang is an internationally recognized specialist in the field of Marfan syndrome, as well as genetic aortic conditions. And Dr. Eric Rosselli is a cardiac surgeon at Cleveland Clinic in Cleveland, Ohio. He is the chief of adult cardiac surgery, as well as the director of the aortic center there. He focuses on surgery for thoracic aortic aneurysm and dissection, and performs approximately 350 of these surgeries a year, including minimally invasive aortic valve repair, complex aortic operations, transcatheter procedures, and high-risk reoperation surgery. Dr. Liang and Dr. Rosselli are also members of the John Ritter Foundation's Professional Advisory Board, and we thank them for their service there as well. So with that, let's get to the facts or the fictions, or it's actually a nuanced area, which is a less satisfying answer, but probably a more frequent one. So we'll go ahead and get started. Okay, so for the first question for our panel, I wanted to ask about survival of aortic dissection. This is one of the most common questions I see people ask in the patient groups and get emailed to us. And the number that floats around a lot is that 85% of people will immediately die from an aortic dissection, or the converse of that, only 15% of people will survive. So how does our panel feel about that survival number?
I mean, it's probably a little bit pessimistic.
Mm-hmm.
It's hard to know for sure because obviously some of the deaths never get found, and so they'll be written off as somebody died of a heart attack. So we probably miss those. So I think there's a certain percentage. I mean, I prefer to focus on the ones who survive I think, there's a big difference in the old days. I mean, it's not like you have chest pains, you just sit there and say, "Oh, I'm a goner." I think, the getting, if you get to the hospital, survival rates, I mean, there's still mortality no matter what it is. I think in hospital, depending on where you get to and what your stage you get to, 20 to 30% will pass away still, despite the best of care with a type A dissection. Type B is very different. Probably 5 to 10% initial mortality. And the numbers that die immediately are hard to know. It's very hard to know. I mean, I've heard 50%. That's probably pessimistic. Die immediately. I don't know. Well, I mean, what's your thoughts, Eric?
I think we absolutely don't know. We really don't know what happens to people who die at home. There was one study that was done in Tokyo where two universities had explored this in a little more detail. Is an emergency medicine based study. They looked at all the people who died of sudden death. They all got an autopsy, and then all of those patients or folks who died also had a CT scan done. And over 8% of the causes of death were ascending aortic dissections, which was a surprisingly high number. But I don't think that means that we can say how many people with a dissection die and don't make it to the hospital. What we do know is that once the dissection occurs, it's not like we have a golden hour or something like that, like we see with stroke or MI. There's kind of a variability in sort of how acute it is. And I tend to think that at least, the folks that we meet that make it to the hospital, we kind of have this window of probably, a half a day or something like that between when symptoms begin and people start to get in trouble without some care. I mean, we want to do it as soon as possible, but sometimes it's just, unfortunately, either a misdiagnosis, which I think we're doing much better at sort of battling that and improving awareness, thanks to the Ritter team and everybody else. There's a lot of variability in how people present. I agree. Like 15% survive after the event and get care is way pessimistic. I think it's a lot higher than that.
Okay.
But nonetheless, we don't want anybody to have a dissection. Let's find the aortic disease beforehand and do a prophylactic repair, right?
Well, I think that's actually probably a very important message, right? And also, even if we don't get in time with the prophylactic repair, knowing about it, that you have the aneurysm will improve your awareness and get you to the hospital much faster and get the right care done properly. So I think here knowledge certainly can improve your outcome. Hopefully, like Eric said, much prefer to operate before the dissection, because your mortality rate, the difference is between 20 and 30% versus less than 1%, right? So definitely want to try to do these things prophylactically if at all possible.
And I think mortality rates actually get better. It's probably, I mean, you look at even IRAD data, which is multi-center, and they're not all expert centers in there. It's kind of moving to less than 20%. Getting better.
Yep. So get to the hospital. Don't ignore your symptoms.
Okay. And 85% is probably pessimistic, but we don't know the real answer.
Right.
Okay, so next, Elena, I'm going to ask you to speak first on this, and that is the big one. All dissections are genetic.
Right. So yes and no, to some degree. I think that what people mean or what people think of when you say genetic is a highly heritable condition that's passed down generation to generation, right? That causes a high risk for aortic aneurysm and dissection, like Marfan syndrome or Loeys-Dietz. And so in that sense, no, all individuals with aortic dissection don't have one of those syndromes like Marfan syndrome, Loeys-Dietz, or a heritable form, that increases your risk, greater than 50% and is passed down, through generations. But to some degree, disease processes are genetic, high blood pressure, hypertension, these other things, they run in families. And so it's likely that a lot of individuals have, a bunch of, minor genetic variants that increase disease risk above general population. And when combined with other exposures or high blood pressure and whatnot, that leads to aortic dissection perhaps sooner, and or increases the risk. So I think genetics plays a role in pretty much all cases, but most cases are not due to genetic syndromes like Marfan syndrome, Loeys-Dietz. So my answer there is yes or no, yes and no.
Nuance. Any other opinions?
I think we have a lot to learn there, right? So if we look at a dissection database, like we have over 2,000 acute dissections in our database. Not everybody had been screened in the older series, but a more recent sort of collection, and somewhere around 10% maybe have something that we've identified as a known genetic mutation. A lot of those things are maybe a point mutation, though, right? In a one single thing that can explain it. And I think, as Elaine said very clearly, we're going to learn more, and there probably is some vulnerability. Hypertension gets blamed as a problem, and we definitely have to pay attention to hypertension. But thank God it's not just hypertension causing the dissection, or we'd see way more of it. So many people have hypertension, right? I mean, you have to have some sort of underlying vulnerability that hypertension is unmasking, I think. And as we learn more, we'll be able to figure it out. David, you probably see a bunch of families where we know it's a heritable condition in their family, and yet we don't know what the genetic sort of connection is there, don't you think?
Yeah, no, I think it's very true. I mean, and I think it's a spectrum, right? From the single gene mutations like Marfan, Loeys-Dietz, ACTA2, and those typically present younger, right? So the younger population. But certainly, if you look in the older population, I always ask family history when I talk to my patients who have a dissection, and you often find that, that there's something there. We can't find the gene yet, but something is there, and and it's probably multiple factors. It could be that there's some genes we don't know about. It could be that it's some vulnerability and when you put them in the right environment. And there probably are some that are purely environmental, but I think, if you get hit by a car, whatever. But I think, there probably is something in terms of the substrate that makes you at risk. And so in some ways you can think of it, okay, I think it's the tendency for this to be familial, okay, whether that's because of lifestyle or genes, is very high. And so I think, for I don't know if everybody should have genetic testing. If your dad has a dissection, he's at 75 or 80 years of age. I mean, that's a moving target as well. But I would say that, certainly I would get an echo, take a look, right? I mean, I think, having a first degree relative with an aneurysm or dissection does confer a risk. Okay, we may not be able to find it by genetic testing, but I think, you're a high enough risk that, an echo is a pretty benign thing, and, it takes a few minutes and could wind up saving your life.
Yeah. And you bring up a good point that, I think it's worthwhile to not classify a dissection as genetic or not, because people can have a familial pattern or early onset disease and have negative genetic testing, but it doesn't mean it's not genetic just because the testing is negative. And that's why echoes are important regardless of age and genetic test results.
Okay,
Yeah,
so
really
preempted my follow-up there about the 40-year-old with negative genetic testing. And, we get that question a lot. People will write in and say, I'm in my 40s or 50s and I had a type A dissection. My genetic testing was negative, though. Is it because I had high blood pressure, or it was because I, used drugs in my 20s, or, any of these other sort of things, or I'm a smoker, I'm overweight, even, things like that come up. So how would you kind of address that with a patient and would you recommend screening for their family? It sounds like yes, but
Yeah, I mean, I think that, the classic example is John Ritter, right? There's no question his is familial. We don't have the gene. I mean, we've tested, postmortem samples. We tested John's brother. In likelihood, John's father, Tex Ritter, probably also died of a dissection. And so, yeah, that's a classic example where, okay, there's definitely something in the family. It's a gene we don't know about, probably in their case, because of the high penetrance. But I think, I think we certainly, if we can find a gene, okay, and we're confident about that gene being the cause, that's great. That's a super powerful tool. But, if you can't find a gene, and it happens unfortunately too often still, then yes, then we do something a little bit lower brow, which is echoes or CTs, depending on where we need to look.
Yeah, I think if you're 40 and you have a dissection, I don't care what the genetic panel says. There's something there's, I would say it's like looking for a needle in a haystack. You need to know what that needle looks like to find it. There's still a bunch in there. Still a bunch of needles in there. Don't go jumping into that haystack, right? So we need to just assume that if you're 40 and you've had a dissection, there is something that, that very likely to run in your family. You may be the first person in the family to have this, but we should screen all first degree relatives for sure. I've got a family that unfortunately, one of, I think it's 7 siblings, brother died, and they screened all the family members, and we've since operated on 4 of his brothers. All the genetic analysis has been negative so far. There's also, next generation kids who are affected with aneurysms who are in a watchful waiting pattern right now. But that brother who passed away saves all of his siblings' lives. And they had surgery a little bit later in life, like, 60-ish.
And do you manage based on that family history? So for me, I would say to that family, before genetic test results even came back, there's something going on, right? Like you mentioned. So as far as management, I mean, are you managing it like a quote genetic case?
Yes. Yeah. I do that with someone if they're younger. I just assume. And so what you mean is keep a low threshold to operate, right? Yeah.
Yeah. And screening and yeah.
For sure. I'm not maybe replacing their aorta when it's 4.2, like I might for TGF beta receptor 2 patient or something like that. But we're definitely keeping a low threshold. So if we see a little bit growth or, 5 centimeters is that, or area to height ratio greater than 10, like that is definitely an indication in those folks. We're pretty aggressive about treating them, especially if there's been dissection.
Yeah.
Okay, our next myth or truth, I guess, is that aortic disease can affect young and healthy people. We often get people who write into us and have some version of, I'm a marathoner, or I'm do jujitsu, or I, have a really active career that's really physical and I'm so fit. How can this be happening? Can this affect young people who otherwise don't have risk factors like hypertension, for example?
Yeah, I mean, I think that's one of the challenges of aortic disease is because it's totally asymptomatic. Like I said, vast majority of cases, it's asymptomatic until something bad happens. So I don't want everybody to go panic and and stuff. But just because you feel good, you shouldn't ignore the other signs or other risk factors, right? So if you have family members who have had events and such, or have other features, then don't ignore it just because you feel good, because unfortunately you may feel good until the dissection happens.
Yeah, and it's a different disease process than like coronary artery disease that people think of. I think it's the heart disease, right? I'm not overweight, I'm healthy. I think that there's a disconnect, and it's just different. It's a different disease process, and not that classic heart disease. So it happens in young, healthy people.
Yeah, I think heart attack.
Kind of goes back to that genetics thing. I mean, you don't know what's happening. You know, I've been saying it a lot more, you know, while I'm on the podium talking about aortic dissection. It's not really a disease. It's a manifestation of probably a whole bunch of other things that are leading into this late degeneration of the aorta. So, as we learn more about, you know, why this occurs, we'll appreciate sort of kind of who it's happening in, but it can kind of affect anybody. Doesn't matter what you look like on the outside or what you do for yourself. Certainly continue to take care of yourself,
Right.
but and be athletic and everything else. I mean, we've had dissection survivors go and run marathons afterward. I don't recommend that. I don't recommend anybody run a marathon, but I think running is good.
That.
You know?
Yeah, we had a marathon or a dissection survivor run for Team Ritter last year in the New York City Marathon, who I believe is a patient of yours, who came from a long background of running previously, though. But I think we all were a bit nervous about it. But it went great, and he's doing great. David, you were kind of already addressed this, but symptoms of aneurysm, not dissection. I think sometimes when people know they have this diagnosis, there's a lot of hypervigilance around any sort of symptoms or sensations or out of the normal feelings they might have, which is completely, you know, normal and understandable. Some of the most common ones I get asked or I see asked are, if I'm tired, fatigue, does that mean my aneurysm's growing? Shortness of breath, hoarseness, all sorts of things, trouble swallowing. People will say, does this mean that my aneurysm is getting too big if I have some of these symptoms?
So, I mean, I think you're correct. Some of those symptoms can happen. I mean, unfortunately, most commonly as the aneurysm is growing, you don't feel anything, right? So that's the most common symptom of aneurysm growth is nothing, which is why continued monitoring is absolutely important. Okay, there are some symptoms that obviously mention. You know, people do get hoarse, especially if it's an arch aneurysm that's getting big enough that's pressing on the larynx or pulling on the recurrent laryngeal nerve. Hopefully, we don't get to that point, but yes, it is. People can get fatigued, especially if the aneurysm is getting big enough where it's causing the aortic valve to leak. So it could be fatigue, shortness of breath, those sort of symptoms. Some patients will experience discomfort, especially when the aorta is growing fairly quickly. Generally, if it's a very slow, gradual growth, most people don't feel anything. But as the aneurysm, if the aneurysm starts to grow more quickly, they often will experience pain. You know, usually it's more constant pain. I mean, a dissection, you know, I'm sure you hear, you know, usually often very abrupt. In fact, mostly it's very abrupt, very severe. Some people, as aneurysm grows more quickly, will feel more of a sort of an aching, you know, sort of pressure pain. Just to use probably nobody knows for sure, but you know, we're probably stretching the nerves on the outside of the aorta when it's growing quick enough to do that. But I think that's still the minority of cases. So if you're asymptomatic, don't ignore it. I tell my patients, look, if you're getting symptoms that you don't understand or something that worries you, call me and let's talk about it. You know, and you know, if it hurts because you turn your chest to you turn over in bed to the right, okay, it's probably not your aneurysm. But you know, if you're just sitting there and you're feeling this aching in your chest that wasn't there before, then yeah, let's take a look. I know it may just be that you're anxious, but it could also be something real, and sometimes it's just very easy sort of sorting it out. And this is a challenge. This is a very common challenge I have with my patients who've been recently diagnosed. You know, you become very, very aware of everything in your body, right? And it takes a little while to sort of get comfortable with your body again, right? Because prior to this, you just wrote it off that you were on the computer too long last night, and it's difficult to do that after a while. And then it takes a while, and you know, I tell my patients, okay, it may mean we're going to make a couple of extra trips to the emergency room to get some scans until you understand your body a little bit better again. You know, so unfortunately we're imperfect. You know, we don't come with onboard diagnostic ports that we can plug in and check what's going on, and so we have to sort of figure it out in many cases. So, but most commonly it's asymptomatic, which is why the monitoring is so important.
Yeah, I'm going to disagree with you a little bit, David, in your comment about the achy part.
Mhm.
I think that's not the aorta.
Uh-huh.
You don't feel your aorta until it's killing you. And I think we need to tell people that, because I mean, people get the diagnosis. I think that a lot of that pressure is anxiety, which is real. And
Mhm.
yeah, look again and reassure people for sure. But I don't think you feel it until it's rupturing or dissecting. And that's a problem. And
Yeah,
otherwise,
no,
that's I guess the only subset where maybe they have some symptoms like this fatigue thing is when they have aortitis, because they've got this kind of diffuse vasculitis kind of process going on. But that's rare.
yeah. No, I think you're probably right. I think it's minority cases, but there are some cases like somebody who's got a relatively, early and let's say following a type B dissection, when they're growing more quickly, they'll feel that discomfort more. At least, I mean, it's always hard to pin on it, but I get the sense that in some cases there probably are feeling pain as the vasovasorium is getting stretched. But I mean, it has to be brought
Maybe
fairly
dissected
quickly.
aorta is a little different. Yeah, I
Yeah,
get that.
yeah. But I mean, I agree with you. I mean, I think the truth is the vast majority, unfortunately, don't feel a whole lot, which is why the monitoring is so important.
Mhm. Okay,
And
Elena,
one other thing, sometimes the fatigue is from new antihypertensive meds, right?
You're blaming me for this, right, Eric?
Beta blockers, right?
It's always the beta blocker. That's what, yeah. It
really
is
good.
not.
And also life. How many of us are fatigued? I see David having his coffee right there. I've
To be
had
fair,
mine
it's
right here.
really
That said, it's okay to drink coffee if you have an aneurysm. No,
Yes,
Very good point.
there's
Very
not too
good
many
point
of them.
I
us.
agree.
Elaine, I'm hoping you can do a little demonstration for us. So I see and there was actually I think it was in the Daily Mail or some tabloid like that, a story about the thumb sign and how this one quick trick can be a way to tell if you have an aneurysm or not. So maybe you can show the viewers kind of what they mean and address whether this is a good test to know if you have an aneurysm or not.
Yeah, sure. So I have to show the big Band-Aid on my arm here because I burnt myself cooking the other day. Don't do that. But the thumb and wrist sign are indicators amongst many that are part of this systemic score criteria for Marfan syndrome. And the wrist and thumb sign are, so this is the wrist sign, which, to be honest, I'm kind of close to positive for. And the idea here is that if you can take your pinky and thumb and wrap it around your wrist and they overlap significantly, it's some degree of a measure of how long your fingers are, proportionate to your palm, because we know that with some conditions, people's fingers are longer, like Marfan syndrome, Loeys-Dietz, etc. And the thumb sign is when you take your thumb and wrap the top part of your fingers around it, and the thumb, I can't do this one, but the thumb kind of sticks out like this, so past your fingers. And the short answer is that doesn't mean you're going to have an aneurysm or dissection. It also doesn't mean you have Marfan syndrome or Loeys-Dietz. However, if you have other features of these conditions or a family history or a known aneurysm, and you have particularly long fingers, long arms, some of these physical manifestations, then yes, that is an indication that you should at least speak to someone about genetic testing or get a genetic evaluation if you don't already know that runs in your family.
What about the one where you bend your thumb all the way back or something? Is that one too?
That's for hypermobile EDS.
Hypermobility, right?
But
yeah. Look how mobile you are.
This is kind of my point.
Would you like echo, Alana? Have you had an echo? No.
Yeah. And this is the point. We have a lot of people in the general population who can do these things, right? I mean, people who are extra flexible and people who have thin skin and visible veins who scar poorly. And so it's really about parsing out, what is just part of the normal spectrum of human variation in all of us, and individuals who are significantly at risk. So I think if you have a bunch of these features, a family history, et cetera, go see someone. But just because you're extra flexible or have long fingers doesn't mean you're going to have a dissection.
And when you say go see someone, can you
Ah.
elaborate a little bit on who that
Well,
might be? If you have access, of course.
anyone here?
Yeah. Okay.
Yeah. So genetic testing is available certainly through genetics clinics. Finding a genetic counselor or a geneticist. However, there are certainly specialists, cardiologists like David, like Eric, like in a lot of these major medical centers where you can get genetic testing and a multidisciplinary evaluation that includes genetic testing in different specialty clinics. And there are also telehealth services that offer genetic testing for individuals who perhaps can't get to a major city or a major center. And those are worth exploring, if otherwise it's not feasible.
Probably should start with a primary care doc if you don't have, we don't want everybody with a flexible thumb to be seeking out a cardiovascular specialist. And I like what you said about the family history, of course, being way more important than any of that stuff, right?
Yeah,
Yes.
I think it's about putting together the whole picture. I think Alana's,
Right.
that it's an important part of it. The workup and whether or not you need to be evaluated is not just one single piece. Some pieces weigh more than others. Obviously, a family member with a dissection weighs very, very heavily. But all these other things comes down to, like Alana nearly has a positive wrist sign. Close, not quite. But
Right.
one piece like that is not enough, right? Because a lot of people have that one piece. But if Alana has a wrist and a thumb sign and is very myopic, well, maybe I'm starting to get more suspicious. And if you add up enough pieces, then you say, okay, well, we crossed the point where, okay, I should go look a little bit further, get an echo, whatever. Although I have a pretty low threshold for the echoes. I echo just about anybody. As Elaine told me, I was sitting in the back room after the fundraiser doing echoes. So I think that's part of the physical exam personally, but that's another story.
Oh, I love that. That sounds awesome. I totally agree.
Yeah.
The echo is such a great tool.
Yeah.
What about there's even other signs that we see that sometimes just happen in isolation but aren't related to aortic disease, but certainly are, I think, maybe raised an even more suspicious sort of flag, like scoliosis, pectus excavatum, some of these musculoskeletal things we see, right? But they can happen just in isolation on any of these other syndromes too, correct?
Yeah, no,
That's right.
absolutely true. Yeah, it's really the constellation that says, okay, when do we cross the line of, okay, what's sort of normal in the population, and okay, we're getting this, that our level of suspicion is high enough, and that line is a hard line to pick sometimes. I tend to have a pretty low threshold just because I get, I think I realize I get fooled often enough that I have a pretty low threshold for looking at people, and hopefully someday our cost system and our medical system will allow us to screen more people more easily, and hopefully we can do that in the future.
Mhm.
What do you
Yeah.
think about the use of non-contrast CT coronary calcium scoring scans as a screening tool?
Well, I think it's a wonderful tool. And actually, I get a fair number of referrals and pickups now from that, which is great because people are using it more often. I think it's a great tool for screening for coronary disease because I think it's in many ways, a better discriminator than simply checking your cholesterol. I've been using it a lot more. My colleagues are using it more. And then obviously that finds a fair number of aneurysms too, which is great. Many of them are not ones you would operate on yet, but it says, okay, now we're there, so we need to monitor them. And so, yeah, I wish insurance would reimburse for it more commonly. But the great thing is that most centers are charging a very small amount of money for them, because insurance isn't paying for it. So they actually are pricing it according to what the market will bear. I think it's a great tool. So.
You know, it's interesting you bring that up. I've had in the past month, maybe 2 kind of extended, you know, in my in-laws, extended family members who have come to me after that test and said, hey, isn't this thing you work on? And one of them, the other day, he sent me his test report and he had a 5-centimeter ascending aneurysm.
My God.
No idea, no risk factors, didn't know anything, thought he might have coronary artery disease. His coronary arteries were beautiful, great, no problem there. But and actually, Eric, I need to ask you about who I should send him to because he's in your extended area. So I'll ask that question.
Yeah, I see a couple patients a month now that have had their aneurysm that I'm operating on that had their aneurysm found because exactly that.
Yeah. Wow. Okay. So I want to talk, we get a lot of questions about supplements because wouldn't it be great if we could just, you know, grab something at CVS or buy something off Amazon that would prevent all these horrible things from happening? The biggest one people ask about is collagen supplements, likely because people have heard collagen disorders as being associated with aortic aneurysm or dissection. So definitely would love to hear everyone's opinions. Should you take collagen supplements to help your aortic health? And then just in general, is there any magic supplement that can save us from dissection?
It would be nice, but unfortunately, I don't think there's any data for any of the supplements. The problem with collagen and any protein you ingest, your body digests it. It doesn't make it out of your stomach. Maybe it has some of the substrates, have a little bit more lysine and whatever you need for your collagen. But the truth of the matter is, no, we have plenty of those amino acids, and it's broken down. So collagen is nothing special unless you inject it into the skin to get rid of wrinkles, like people like me. But no, and then and the other common ones you hear about are like copper, right? And I think copper was one that was circulating for a while. So again, there really hasn't been any data to support them. I mean, they're probably not harmful other than to your pocketbook, but I don't really see, I don't certainly recommend them. If a patient wants to take them because it makes them feel better, okay, whatever. I mean, I don't think it's hurting themselves. They're probably the only one that probably is some discussion about, although I'm not personally a believer in it, is vitamin C for some of the people with vascular EDS. I don't think that's going to work, but I know some people are still some people still believe in it, and there's some people studying that, but I'm not for I don't feel really strong that's going to really work. I don't know. What are your guys' thoughts?
I agree. I agree.
I do too. And I think with collagen, like you have to keep in mind, there are over 20 different types of collagen, right? And the collagen you ingest are essentially amino acids that are broken down. And it's not like you're ingesting this collagen molecule that goes in and zips right to your aorta and strengthens your aorta, right? That's just not how it works anyway. So you're better off really eating a good healthy diet, to get all your amino acids and stay healthy and get sleep and all of that. So with collagen, I feel like probably won't harm you, but yeah, I don't think there's any data to show that it's going to help your aorta or vascular health.
Yeah, it's not going to help. It could be dangerous if you eat too much of that kind of stuff, or you take too much of that. You could potentially have issues with excessive calcium intake, or if you had a dissection and you've had injury to your kidneys or something like that, you got to be careful about taking extra stuff like that. I think just a healthy diet, it makes a lot more sense. Making sure your vitamin D levels are up. Being a guy that lives in the north, we know that that's important. Probably taking a multivitamin is a good idea for most people, but anything beyond that is you're probably just spending money that you could probably spend wiser.
Mm-hmm. Okay. Well, we're in agreement on that one. Don't waste your money. And the supplement industry is, in tears at that answer.
It's appealing. It really does draw you in.
I mean, I can understand the impulse. Okay, I just saw a question. We had someone write into us for the Aorta Advocates program this week that was about, it was a young woman who had a dissection, a type A dissection in her 30s. And she said, I'm terrified that I'm not going to be able to live long enough to see my children grow up because of this. What is my life expectancy? And this was obviously, you know, a younger woman. She does have a genetic aortic condition. But, you know, I hear this from people dissecting at all ages. They want to know, is my lifespan going to be significantly shortened because of this? They go online, and if you Google, you'll see a lot of kind of scary results come up, talking about 5-year survival rate and things like that. I think it's clear that this is a nuanced answer, and there's not a yes or no to it, but it is certainly something that really, I think, weighs on people with this diagnosis.
I think that's very important, right? Because people feel like, and this is where the internet sometimes is a very dangerous place, right? Not putting it in context, right? You know, I think, you know, it obviously depends on details of the repair, what the underlying condition is, that will impact it. But I think, you know, the numbers you see on the internet are very, very pessimistic. And actually, if you look at many of those data, what causes the patients to die afterwards actually is not the dissection; it's what caused them to have the dissection in the first place, right? So, you know, it's still probably you know, a big chunk of people dying who have dissections are older patients, right? They're patients who have been smoking, hypertension, atherosclerosis, and it's those things that kill them afterwards, right? And you know, of course, obviously the dissection itself has a significant mortality rate, and it does impact it. I mean, obviously, you know, many patients, unfortunately, with you know, the dissection will need further surgeries in the future, but you know, in the right centers, those can be very, very successful. So, you know, I think I tell my young patients who have had dissections is, yeah, I mean, obviously you can't ignore the fact that the dissection has affected your overall health, okay? But I think that many of them will make it to, you know, to Medicare age, which may or may not be a good thing.
I agree too. I think the problem is, even if you read the literature and it describes survival, remember that that's just an average. It's a big chunk of data lumped together. It's not you. It's not any one individual, and we need to like really focus in on that. You are not your genetic code. You are not your diagnosis. You're an individual, and if you have survived from an aortic dissection event, you do need to come to grips with that and appreciate that you have a chronic condition. So, you know, that's a little bit of concern is okay, as long as it's making sure, you know, it's keeping you sort of on top of appreciating that you have this, you know, you have this condition that you have to manage. And if she's in her 30s, I think there's a really high likelihood she'll probably need another operation sometime in her lifetime. But I don't know when that is without knowing any of the details. And I can tell you that I have a ton of patients that I've replaced their whole aorta in multiple stages, and we stage it out, and we replace segments of the aorta one bit at a time so that we can get them back to living a normal life. So I think for especially a young person who's otherwise their other organs are functioning okay, we can keep them on track to have a pretty normal lifespan. You just have to make sure that you manage your blood pressure well, you get your follow-up imaging done, and don't worry too much if you need someone tells you you're going to need another operation. Just make sure you get connected with a team that really knows how to handle that.
Yeah, and I think probably one good point, and sometimes that gets missed a lot, Eric, is that you said, you know, you've had a dissection, now you have a chronic disease. And oftentimes people, it doesn't get conveyed to the patient after the dissection, right? They'll get the operation, the aorta's fixed, and then they get sent away.
Yeah.
They're like, and they don't realize, okay, they need to be followed, right? And because, you know, like you said, you can do things, okay? It can be done very successfully, okay? So it becomes a disease that needs to be managed, but it can be managed, right? And that's the key. And you don't ignore the fact that you've had it. And if you can do that, then yeah, I think outcomes can be great.
Yeah, so it might not always be, even though people ask, what is my life expectancy, a number that's satisfying even, but more, you can do something. Here's what's in front of you. You have opportunity. You can see your kids grow up. You know, this is what we need to do to keep you in that position moving forward. And I think that is a good message. And before you have a dissection, if you know you're at risk, that also, contributes to a better outcome. So that's where it goes back to, you can't pull up data on the internet and plug yourself into any one of those pools because there are, it's a broad spectrum and there are things you can do to shift that.
We sometimes have people share on our social media, especially, it's been X number of years since my dissection, and it's always really fun to see, like, someone will try to up it by, besting their number. And Meredith, who is our CEO, her mom is a survivor. And I think she's at 34 years, I want to say right now, post type A dissection in her 30s, and is doing great, enjoying her grandchildren, enjoying, traveling, being her life. So there definitely are a lot of stories. And I think Dr. Prakash shared with me, he has a 49-year survivor that he takes care of. So there's definitely stories out there that of people who have lived a very full and long lives and continue to do so. Okay, so the last question that will fit in here, and we have so many more, so I want to do this again because this was kind of fun, and I feel like I've learned from it too. And it kind of goes into living a full life. So thinking about exercise, sex, pregnancy, all of these things that make up all of our lives, whether we have aortic disease or not. If you, for example, have an aneurysm, can you exercise? Should you exercise? Is it safe to have sex? And I guess same after dissection if you're living post-dissection.
I mean, those are very important questions. To a degree, you have to individualize them, okay? And I think there's going to be some controversy about this as well. You're very curious to see what Alana and what Eric feel about this issue. I tend to believe that, okay, your aorta is one part of you, but you need to keep the whole rest of the body and the rest of the mind healthy, right? And that includes activity, sex life, all those things, right? And I think it makes sense to be aware of it. So like, you shouldn't go out there and become a bodybuilder. It's probably not a great idea, may not be a great idea for anybody. But getting out there and being healthy, being active, I actually recommend that many of my patients, even with it, depending obviously the status of their aneurysm and their dissection, actually do some resistance training, because I think maintaining muscle mass, because like previous question, okay, I expect my patients to live a long time, and maintaining a degree of muscle mass is important for for a quality of life later in life. So I definitely encourage them, but you should modulate it. Obviously it depends on the exact situation. If you just had a dissection, okay, maybe cool it for a little while. And, and certainly for the first, 6 months to a year, I tend to be very restrictive just because the aorta is kind of delicate. But, the goal is to get people back to being active. And there are many good things about exercise. And this is something where you have to work with your surgeon, your cardiologist, your doctors, and saying, okay, what's a reasonable thing given your current status? So.
I totally agree. I like what you said. Well, first of all, everyone should be able to have sex. Get that question. Like that should never be a contraindication. And everyone should be exercising too. And how you exercise, I think, is important. And it drives me a little crazy when people come to see me and someone told them, like, you can't lift more than some ridiculously low number. 10, 20, 30 pounds is so little. If your aorta is that fragile, I will fix it right now, today. I've had people come in and their doctor had told them don't get constipated, and they're so scared. That's a horrible message to be delivering to patients. So that's a myth we need to crush. You need to be active. You need to exercise. I love it, David, that you're talking about people doing resistance training. There's a ton of data that shows that muscle mass correlates with survival in human beings. I mean, that is key. Powerlifting is probably bad. Because when you really lift something that's excessively heavy, that's when you have spikes in your blood pressure. And so what that number is for any individual is pretty variable. As a general rule, I tell people don't lift more than about half your body weight, but sometimes there's guys that come in that are, I'm afraid when I shake their hand, they're going to crush my hand, really big guys. You can't tell that guy he can't lift 30 pounds or even 50 or 60 pounds, because that's nothing for them. So we need people to stay active. And if I could just make one more comment about this too, it is normal to have these fears though. So we surveyed dissection survivors in 2 different big surveys that we did, and we asked everybody about the event, which everyone pretty much remembers to a T, with like a photographic memory of the event. And we asked them what was happening at the time. And it's a normal, natural human sort of instinct, I think, to correlate things that are coincident in time, when there's something bad, as causative, but it's probably just coincidental. So 15% of people had their dissection when they were asleep. We don't tell them not to sleep anymore, right? And the poor 2 or 3% who are engaged in sex when it happened, I have to convince them it's okay to have sex again. It was bad timing. And there was a whole spectrum of things that people were doing, washing the dishes. Maybe 25% were doing something that they considered sort of a strenuous activity, but that's true of all of us throughout our day. So I think we need to worry less about sort of limiting people, and focus more on sort of healthy behaviors like maintaining your blood pressure, getting your follow-up with your doctor, making sure that don't be afraid to go to the hospital because you're going to see Dr. Liang. He's going to take care of you, even though that's a place that kind of gives you bad memories.
Yeah, I agree. And I think that there are a lot of pieces of people's identities, like playing golf or running or cycling, that are important. And the data really does show that if you give up all of these things and feel so restricted, you're more likely to get depressed and have a hard time, and less likely to follow up and maintain these healthy behaviors long term that will, really serve you better. So it is important to still do what you love. The diagnosis doesn't need to take everything from you. And I think it's just about working with your team to do it safely.
I think the lowest number I've seen someone write to me about is an 8-pound weight limit, which I thought, I don't even think that's a bag of groceries.
No, we should send like an 8-pound Christmas ornament to whoever recommended that,
Yeah.
8 pounds. Yeah, that is crazy.
I
don't even know what
I
to
don't
do.
know. Maybe it was you, David, who gave the example of every time you stand up, you're squatting half your body weight. Was that you?
That's exactly right. And I think Eric is, I think that's a very important point, is what are you doing? How are you doing it? Right. And who's doing it? Right. There are some people, maybe there's somebody where 8 pounds is too much, probably maybe my mom who's 92, 8 pounds might be a little bit much, but I mean, I think, who it is, it makes a big difference. And I usually tend to focus on, okay, how does it feel to you? Right. If it feels like you're having to hold your breath and grunt in order to do it, well, probably not a great idea. But if it feels comfortable, right, and it feels like, yeah, I can get a little bit of a burn in the arm and whatever, it's probably good for you.
Bring your groceries in. It's okay.
Yeah. Groceries.
Well, it depends on whether you shop at Costco or not.
Oh, I don't shop at Costco. I can't comment on
Okay, well, we have about 40 questions back, so I'm going to put you all on the spot and ask you to come back and answer more or address more of these myths, because this was fun. So yes.
Sure.
I enjoy the conversation with you guys. This is great.
That's great. Yeah.
Okay, thank you so much. Thanks for your time today and your candor on these questions. If you're watching this and you have questions about things that have come up, obviously address this with your medical providers, but you can also write to us at the John Ritter Foundation, and we may be able to provide some resources or connect you with aortic providers who can offer advice, or take you on as a patient, including these wonderful speakers we had today. So thank you all for being here. And with that, please see the notes in the description for further information. Take care.
Thanks, Ellen.
Take care.